today we're going to talk about hospice plans of care and how to avoid COP problems and how to avoid problems on your surveys. All Medicare certified hospices have two conditions by which they have to abide: a condition of participation as well as conditions of payment. Both obviously are very important. The CMS state survey agencies look at our conditions of participation, making sure that we are doing the things that are required in terms of outcomes and processes. The MACs, or fiscal intermediaries as they used to be called, look at our conditions of payment along with other oversight bodies like the RACs and the ZPICs, and they look to make sure that we are complying with all the requirements for getting paid. Two different entities are reviewing the conditions of participation and the conditions of payment, but we have to pay attention to both of them. And the plan of care is showing up under both categories as a problem. So under the condition of participation on the surveys that CMS has our state survey agencies conduct, plan of care is an issue for hospices, as well as under the top 10 reasons for medical review denials. So how we conduct our plan of care not only impacts what's happening with our patients and the outcomes for our patients and our results on survey, it also impacts what happens to payment for the care that we provide and our cash flow. So that's why it's really important to take a look at how are you developing the plan of care, how are you implementing it, and are you following it? And that's what we're going to talk about this afternoon. So the plan of care really is the roadmap for the patient's care. And as such, hospices should be providing care as it is stated in the plan of care and should be building the plan of care on a firm foundation, which really is the patient's initial and comprehensive assessments. And we'll see that as we move through our discussion today, that everything that is on that plan of care comes from the assessments that our nurses, our social workers, our chaplains, and our other disciplines perform. But those assessments do drive the plan of care, and that plan of care should be used as the roadmap for everything that the IDG does. And I'm really disappointed and sorry to say that when I attend IDG meetings in hospices or I see visits being performed, more often than we'd like to see, the IDG member does not utilize the plan of care and the assessment to plan the visit. And when I go to the IDG meetings, I don't really hear the IDG talking in terms of the plan of care. Both on the visit and on the plan of care, we seem to fall, or excuse me, the visit and the IDG meeting, we seem to fall into habits of talking about the last visit or talking about one particular problem that we're having with the patient instead of looking at the overall plan of care for the patient and what it is that we're trying to accomplish. Have we accomplished that? What's been the patient's response to our interventions? And that plan of care pulls everything together for us, and we really need to focus more on that. We're getting better at it, but it is still not as integrated into our IDG activities and daily activities of our clinicians as it could be. And we're going to see the consequences of that during the time that we have together today. This next slide shows the regulations that are applicable to our discussion. I really just want you to have this as a reference. It gives you the actual condition of participation citation at 418, and then also gives you the LTAG citation. And we'll talk a little bit about where to find those LTAGs in the next couple of slides. So the top 10 hospice survey deficiencies. These are from calendar year 2013 for all Medicare certified hospices that had surveys during that year. CMS gathered all the information from the state survey agencies and categorized them. So for calendar year 2013, just like calendar year 2009, 2010, 2011, and 2012, plan of care is the #1 survey deficiencies. And it is bothersome that that has been the #1 deficiency since 2009. And specifically for calendar year 2013, we're looking at LTAG 543. And then you can see here the rest of the top 10 hospice survey deficiencies. And most of these relate to either the plan of care or the assessment. It's the content of the plan of care. It is whether or not we're following the plan of care and the coordination of our services and frequency of visits. So most all of these relate to plan of care or assessment. And we're going to see how the survey process actually occurs. We need to talk about that in order to understand how we can be impactful in our actions with the plan of care. The surveys that CMS has the state survey agencies conduct on their behalf are actually conducted based on guidance from CMS, and that guidance is found in the State Operations Manual. This is the guidance that is the instruction for the surveyor on how to conduct the survey. So you can see exactly what the surveyor is going to ask for, when they're going to ask for it, how they're going to ask for it, what they expect from you. That is all in the State Operations Manual under Appendix M, and here is the link to that manual. The hospice instructions on how we are supposed to perform are partly in this surveyor instruction, but they're also in the federal conditions of participation. The federal conditions of participation drive the State Operations Manual, and it is the State Operations Manual that uses the LTAGs that we saw on the previous slide. You'll see here I went ahead for all survey deficiencies and gave you the actual regulatory citation as well as the LTAG so that you could look up specifically what the interpretive guideline is for that particular citation that we're seeing in calendar year 2013. But all surveys are outcome focused. And the secondary focus of the surveyor is on our process. Now, part of the problem for hospices is that our federal surveys are only conducted or have to be conducted once every 7 years. And actually, that's a guideline from CMS. There is not any statutory language that directs the surveyors or CMS to make sure that surveys are conducted in that time frame, like there is for home health and some of the other healthcare providers. And by not having surveys frequently, we don't realize sometimes what it is that we might not be doing correctly. You will see that your hospice's outcomes, which really means your hospice's quality patient care, will improve when the tools that you have available, such as the plan of care and the assessment, are used properly and more frequently in your organization. And then hopefully once every 7 years when you're surveyed, you're not going to have a problem with your plan of care. But the survey is like a test for us or a performance evaluation, and when you're not receiving feedback, you don't always know how you're doing. So hopefully in our discussions today, based on the feedback that other entities have received, if you've not had a survey, you'll get some feedback on how you're doing and compare yourselves to some of the examples that I'm going to share with you of problems that surveyors have identified, and then also how we can use that plan of care to help improve patient outcomes. And you definitely get right to the outcome by using your roadmap, which is the plan of care. Now, the plan of care is actually based on the patient's assessments, and you'll see later that that's one of the problems that the surveyors found, is that the documentation is showing that the plans of care aren't always based on assessment, but we are going to talk first about those assessments, what needs to be in them, when they need to be conducted, since that really is the base for the plan of care. The initial and the comprehensive assessments are not the same thing. In talking with some of the hospice staff, and even in talking with surveyors when they interview hospice staff, they will ask, show me your initial assessment and your comprehensive assessment, and the staff will give them one document. And the staff doesn't differentiate often between the two because many hospices have a practice of completing both simultaneously. You absolutely can do that. There's not a problem, but they are different. And your clinicians who are completing them need to understand those slight differences between the two. The initial assessment is the assessment that has to be completed by the RN, unlike your comprehensive assessment, which is completed by all members of the hospice interdisciplinary group, including the attending physician if the patient has one. So the initial is just completed by the RN within 48 hours after the election of hospice care is complete, unless the physician, the patient, or the representative requests that it be completed in less than 48 hours. Having it completed later than 48 hours is not an option. And I've had many hospices say, well, I documented it that the patient's family didn't want me to come out for 3 days after they signed the election. That really is not an option. The only time you may change this 48-hour time frame is to move it up. And we cannot forget about the attending physician. As we talk about the survey deficiencies, you'll see that one of the people missing from the entire IDG is that attending physician. We are not doing a job that convinces the surveyors by looking at our documentation that we have included that individual in the assessment, in the plan of care, and the updates and reviews of those documents. So I just want to stress, don't forget about the attending. By definition, they are the one most involved in the patient's care. And I'm going to skip off of the plan of care for just a moment and talk about how not including the attending physician is impacting hospices outside of surveys. One of the recommendations that CMS has made in the fiscal year 2015 proposed rule is that hospices will have to have on the election statement an attestation basically from the patient indicating that they have chosen their attending physician, and if there is a change in that attending physician, there is a similar type of documentation and signature from the patient indicating that they've made that change. The attending physician, it's patient's right to choose that individual at the beginning of care. So we should be asking them who that person is. Now what I hear from hospices is logistically that patient will give a physician name, but that physician really doesn't want to be involved. They want courtesy calls and updates, or they only want to be involved in certain aspects of the patient's care. When that situation occurs, the hospice should go back to the patient and indicate that the chosen physician, let's say Dr. Smith, really does not want to take on the role of the attending physician, or Dr. Smith would like to take on a role in conjunction with another physician. Maybe Dr. Smith only wants to focus on the COPD issues that you're having and he does want us to communicate with him on those issues, but when it comes to some of the other symptoms, he really wants us to utilize our medical director for that. Would that be okay with you? It is the patient's choice. Also, once that initial benefit period that you get your certification from the attending physician and from the hospice physician, once that period ends, it doesn't mean that the attending physician is no longer involved just because they do not have to sign the recertifications. It simply means that they don't have to sign the recertification. Only one physician is required to certified terminal illness on a recert. 2 are required on the initial cert. So the attending physician doesn't go away. That attending physician is still involved. The hospice physician picks up when that attending is not available, and if the attending decides that they don't want to be involved, they don't want the plans of care, they don't want to be called for orders, you need to go back to the patient and get a different attending physician. And if they choose not to have an attending, that's fine. If they choose your medical director, your hospice physician, that's fine as well, but they shouldn't be forced to do that. And you as a hospice have to make sure that your IDG team knows who that attending is and that there's communication primarily with that attending physician, and that communication is documented. Okay, let's get into the initial assessment. I already told you that it has to be completed by the RN and what the time frame for that is. And the purpose of the initial assessment is to identify the physical, psychosocial, emotional, and spiritual needs of the patient that are immediate. This is where your nurse would go in and she would assess, what does this patient need me to work on right now so that I can do a more comprehensive assessment. This is the initial assessment that's so helpful when you see that a patient is actively dying and they have some symptoms that really need to be addressed. Your nurse can complete her initial assessment and focus just on those immediate needs, pulling in the social worker and chaplain as necessary. They may not need to be pulled in, or maybe they have a bigger role than your nurse plays. But the initial assessment should be looking at the individual, their individual unique circumstances, and looking at what their immediate needs are physically, emotionally, and spiritually. And again, part of the problem on surveys is that the plan of care is not developed from these assessments. So we're going to talk about what's necessary in those assessments as we go throughout our time this afternoon. The comprehensive assessment is different than the initial assessment, and it also has to identify physical, psychosocial, emotional, and spiritual needs related to the terminal illness that have to be addressed for this particular patient. But we're looking beyond now the immediate needs. Now, a question that comes up frequently is, what do I do if on the initial assessment I'm supposed to address psychosocial and spiritual issues, but my RN is the one who has to complete it? Well, your social worker and your chaplain should be collaborating with your nurse and developing an initial assessment tool, if you don't already have one, that includes enough information on it that can be gathered by an RN and then shared with the social worker and chaplain so that the group in its entirety, bringing in the physicians, would also be able to identify the problems for this particular patient that you're going to address. Because that's what the assessment does. It identifies the problems. The plan of care then identifies the interventions and the goals associated with those problems. CMS has specifically stated that the assessment would include an assessment of certain areas, but not be limited to screening for needs in all of these areas. And that's what this slide here shows for you. So you're screening for pain, dyspnea, nausea, vomiting, so on and so forth. The hospice would gather information as necessary in each of these areas at minimum to meet the patient and family needs, and that comprises your comprehensive assessment. Sometimes the surveyors aren't seeing all of these required areas addressed on assessment. Specifically, spiritual needs might not be addressed, emotional needs, or the family's need for counseling and education. So you want to go back and look at your actual documentation for your initial assessment, make sure everything is included, as well as for your comprehensive assessment. Most hospices will have a comprehensive assessment that includes a nurse's initial assessment, or her initial visit, I should say. The initial assessment focuses just on those immediate needs of the patient. But that first visit that the nurse makes, where she does a comprehensive assessment, That particular piece of documentation is included as part of the comprehensive, as is the social worker's psychosocial assessment and the chaplain's spiritual assessment. Usually all of those documents together comprise the comprehensive. If the social worker or the chaplain is refused by the patient or the family, what do you do about that? Well, your nurse then would have to do a comprehensive psychosocial and a comprehensive spiritual assessment. Do you need to use the same forms that the social worker or the chaplain would use? And the answer to that is no, especially if those forms would take the nurse outside of her scope or outside of her comfort zone. What you would need to use is, again, a tool that would allow the nurse to gather enough information for the social worker or the chaplain to be able to then, as a group, identify the problems, the psychosocial problems, spiritual problems, physical problems of that patient that need to be addressed by the team. Okay, so the comprehensive assessment has to take into consideration these 5 bullet points, and this is specifically listed in the conditions of participation and in that surveyor manual. So when the surveyor pulls out a comprehensive assessment, they're looking to make sure all of the items on the previous slide were addressed, but they're also looking to make sure that there's documentation concerning the nature and condition causing admission. That can be something that's referenced on the comprehensive assessment as being in another part of the chart, but there should be some summary there about why now this patient is all of a sudden admitted to hospice. Complications and risk factors that affect care planning. That is something that's typically always present. And the patient's functional status usually is not an issue. Those 2 things are usually evident in the documentation. The imminence of death and the severity of symptoms sometimes are not present when the surveyor is reviewing the documentation. The imminence of death is not, well, the patient has 6 months because they're terminally ill. What CMS is expecting here is the patient actively dying? Are we talking a couple months? Mainly it's whether or not they're actively dying, and just documentation of that. If you don't have on your comprehensive assessment a prompter for your nurse that says imminence of death, you may want to consider adding one, or you may want to educate your nurses that they need to identify whether or not the patient is actively dying or imminently dying. Severity of symptoms. What surveyors have indicated here is that they'll see that the patient might have some shortness of breath, but we don't know how severe that is. And severity doesn't have to necessarily be in terms of a number. It could be mild, moderate, severe. How is it affecting their functioning? Is it present, not present? If it is present, does it prevent them from living alone unless they have certain equipment in the home? That's pretty straightforward. Our clinicians do that assessment for severity all the time, but we don't always document it. Using something like the Edmonton assessment or another standardized tool is helpful in identifying the severity of the symptoms. And the comprehensive assessment also has to have a drug profile and take into consideration the bereavement needs of the patient and family. We need to talk about the bereavement needs in particular because on the comprehensive assessment they do need to be addressed, and oftentimes the social worker or the chaplain will address that in their psychosocial and spiritual assessment. If the social worker or the chaplain are not getting out into the patient's home within the 5 days, or they're refused completely, another member of the team, usually it's the RN, usually not the physician, but the RN would then have to do an assessment of bereavement needs in their documentation. And that is the primary difference in terms of content between the initial assessment and your comprehensive assessment. Bereavement is not necessary to be assessed for immediate need on the initial assessment, just on the comprehensive. Let's talk about the drug profile because it is falling out as one of the top 10 hospice survey deficiencies, And again, as part of the plan of care, we'll see that the drug profile is also included there. But we have to make sure that it is correct, because if it is going to be part of that plan of care, part of our roadmap, part of driving what we do, we need to make sure that there are not duplicate drug listings, and we need to make sure that everything that the patient is taking, whether it's prescribed or not prescribed, is actually on that drug profile. Some of the issues that the surveyors have had is primarily duplicate drug listings or a medication is missing, but on many of the surveys, the oxygen was not listed as a medication, and it is considered a medication. Each hospice, as part of its drug profile, should review all of the patient's medications, and in addition, your documentation has to show that you're monitoring those medications for effectiveness, as well as actual or potential medication-related effects, any untoward interactions. So during each update to your comprehensive assessment, one of the ways that you might want to, I think there might be a problem with folks hearing me. I'm just double checking to make sure that you can hear me now. Melanie, are you there? I just want to do a sound check. Can you hear me?
Katie, this is Cheryl. We can hear you.
Okay, good. I'm sorry.
Yeah, that's okay.
Sorry for the interruption. So during each update to the comprehensive assessment, you want to make sure that as you add new medications, and usually the update to the comprehensive assessment is completed once every 14 days when you do your IDG meeting, and you're bringing on new medications in that 14-day period, you want to make sure that you're doing a full review for effectiveness and side effects and duplicate drug therapy on each and every medication that is added or changed. And when the patient's condition changes, you need to do a review as well. So that means if they're changing their level of care, they are going to have a drug review done at that time, because obviously if they're going from routine home care to GIP or to continuous care, there's been some change in their condition that would warrant that different level of care, which then does warrant an updated assessment. Make sure also that on that drug assessment, I'm going to go back for just a moment, make sure that your drug profiles are done or completed by an individual with education and training in drug management. That's been one of the survey citations. As you look at the LTAG associated with this, and you look at that interpretive guideline, it indicates that this has to be done by a qualified individual, and that qualified individual is defined as somebody who is either a CHPN, Certified Hospice and Palliative Care Nurse, or a hospice physician. So if you're having your nurses who might not be certified doing the drug profile, you want to go back and make sure that you have provided them with some education and training in drug management. Just indicate that in their personnel file, and you shouldn't have any problem there. But I did want to bring that up because that is an area that does cause this to fall out on the hospice surveys. Okay, your bereavement assessment is another area that's falling out and causing a citation here. And we're also seeing, not in the top 10, but we are seeing survey deficiencies in bereavement starting to creep up towards the top 10. In some states, it's within the top 3. So we do want to pay attention to this area as well. And the initial bereavement assessment, remember, that's on your comprehensive assessment. Even though it's called an initial bereavement assessment, it's contained in the comprehensive. And we're looking at the needs of the patient's family and the other individuals, not just the caregiver. Notice that this says other individuals. That includes the daughter who might live in Colorado and not be very involved in the patient's care. If the patient and primary caregiver believe that that person is part of their circle and would want that person to have bereavement services, you must do an assessment on that individual. You're looking in your assessments to make sure that you have something in that documentation that addresses the social, spiritual, and cultural factors for that individual as well as with the patient. Sometimes the patient may have a certain religious belief that impacts bereavement that the daughter doesn't have, but you still need to make sure that in that daughter's assessment you're addressing all of her social, spiritual, and cultural factors, including the fact that it may be different than the patient's. Anything that's going to impact their ability to cope with the patient's death is something that you want to have on your bereavement assessment. And then that initial bereavement assessment has to be incorporated into the patient's plan of care, and then after the patient has died, it's considered in their bereavement plan of care. Now that's a thread that's not always flowing through, and that's why we're seeing the bereavement piece pop up or move closer to the top 10 on the survey deficiencies. And part of it is that this assessment isn't being done completely, doesn't contain all the components, not being done with the right individuals, or that it's not being utilized in the plan of care, and then once the patient dies, it's not at least referenced. Just has to be considered in that bereavement plan of care, doesn't have to drive it. And then, of course, we have to have outcome measures. And since our survey process is outcome focused, the surveyors certainly are going to take a look at this. And I'm not going to go through each bullet point here, but what I will say is that the data elements from your comprehensive assessment must take into consideration aspects of care related to the patient's symptoms. And as we move throughout our slides, you're going to see that sometimes we'll have documentation of a patient's symptom, and it's on the assessment, but it doesn't appear on the plan of care, or there will be symptoms that are not on the assessment and not on the plan of care at all, yet they're seen elsewhere in documentation such as our visit notes. So you definitely want to make sure that those are all identified, and the severity of those could be some of the data elements that move over into your plan of care. And you use those data elements for each individual patient's plan of care. For instance, one of the data elements might be patient's shortness of breath. Is it mild, moderate, severe? How is it impacting their daily functioning? And it is something for this particular patient in our example that would cause them to maybe have some PRN oxygen. So we're going to identify a problem of shortness of breath. The severity of it is moderate, and in this particular patient's plan of care, I'm going to have a corresponding intervention of initiating some oxygen for this patient, and then I'm going to assess the effectiveness of that intervention and the effectiveness of that medication by reassessing the patient's response once that intervention has been initiated. This is basic what our nurses do every day, but it's not showing up in our documentation. We also have to use the outcomes from the plan of care and the assessments in our QAPI program. And because we're not talking specifically about the QAPI program today, I'll just mention that it does have to be involved there. So for instance, what they mean here by using the data elements in the aggregate for your QAPI program is that instead of looking just at an individual patient's shortness of breath, you take all of your patients together in the aggregate and look at how many of them had shortness of breath, and then the outcomes based on your interventions for all of those patients together. Okay, so once you've completed your comprehensive assessment, you want to make sure that you update that comprehensive assessment, again utilizing the individuals who are to be part of that comprehensive assessment. That's everybody in the IDG in collaboration with the attending physician. That's usually what's missing. Not all of the individuals are involved. Sometimes this is too nurse-driven, and it's only the nurse that's doing the update to the comprehensive assessment. Again, even if the social worker and the chaplain are not visiting the patient, are not actively seeing the patient, they still have to be involved in identification of the problems. That's what your comprehensive assessment is, so make sure that they're included. Make sure that you have some documentation about the patient's progress towards their outcome. You'll see that that impacts some of the survey deficiencies as well, and a reassessment of the patient's response to care once you've initiated an intervention. Part of the reason for the deficiencies on the update is that they're not occurring as they should. It should be done no less frequently than every 15 days, but as frequently as the condition of the patient requires. And sometimes we're not doing an update to the comprehensive assessment involving all of the disciplines that we need to involve when the patient has a change of condition in between IDG meetings, because it's typically at our IDG meetings, usually once every 7 or every 14 days, that we update the comprehensive assessment, and sometimes we then forget about it in between IDG meetings, yet the patient's had a change in condition where they might have even gone to a different level of care. And the surveyors are seeing that on those changes in condition, we're not doing that complete update involving all folks. Now again, your comprehensive assessment is an identification of the patient's problems. So your survey deficiencies are based around not identifying all of the patient's problems, as I had said earlier, not including all the folks in the IDG, but then not doing the update to the comprehensive assessment when a new problem is identified, or taking a problem off when it is resolved. In order to use the comprehensive assessment and the plan of care as the tool that it should be in our roadmap for patients' care, you really need to have your clinicians reviewing the updated comprehensive assessment as well as the plan of care in preparation for each of their visits and at each IDG meeting, and whenever there's a change in the patient's level of care. And that documentation should reflect whether or not there's been identified new problems, if the problems you've identified have been resolved, or they're ongoing. And the best way to do this is to actually pull up the comprehensive assessment during your IDG meeting, or even if you're having a small group meeting outside of your IDG about this patient because they've had a change of care, actually pull up that comprehensive assessment and look at the list of problems and say, what's happening with this? Is it new, resolved, or ongoing? And if it's not resolved, what's happening? What's the patient's response to care, and how are they progressing toward goals? Part of the problem in documentation when it comes to condition of payment is that the medical reviewer is not seeing that new problems are identified or that the problems are ongoing. They're not seeing how the patient is responding to care. There's not enough detail there to say that you're progressing towards the goal, but the goal has maybe changed because the patient's condition has changed. If the goal is to get the patient's pain level to a certain level, one of the issues on medical review is that they see that the patient's problems aren't changing, and you've gotten the patient, let's say, to their goal of a pain level of 3 out of 10, and the patient stays that way forever and ever and ever, and there's never a new problem. And I'm sure there is, because you hear about it when you go to the IDG meeting and they talk about this patient. You hear about the changes. You're just not seeing it in your documentation. Okay, so the plan of care. Let's get into the number 1 top 10 deficiency, and specifically addressing L543, which again is in that state operations manual. You'll be able to find not only the actual regulation, but also the interpretive guideline to the surveyor there. All hospice care and services furnished to patients and their families must follow, that means we have to do what the plan of care tells us to do, an individualized written plan of care established by the hospice IDG in collaboration with the attending physician, the patient or the representative, and the primary caregiver, in accordance with the patient's needs, if any of them so desire. So if you have a caregiver who doesn't really want to be involved in the patient's plan of care, document that. Make sure you're involving that attending physician as well as the hospice physician. Sorry about that. And the primary caregiver. We have to discuss what individualized means to a surveyor. When they're looking at that plan of care, if they see that all patients have the same problem, all patients have oxygen, at least PRN. The question is, what on the assessment would cause me to put oxygen on the plan of care? It is helpful as you're auditing yourself to pull out that assessment, pull out that plan of care side by side. Don't look at any of the visit notes in between that. Just pull those two documents out, lay them side by side, and compare. Some other examples of the issues that are being cited under plan of care are, while continuous oxygen was part of the plan of care, it was discussed by the surveyor on her interviews with staff and during a home visit. She observed it. There was no indication of respiratory or airway assessment, no interdisciplinary team note regarding the need for oxygen use or changes in the patient's condition that would then prompt oxygen use. The patient was seen during the surveyor visit sitting up in the chair with no oxygen on or even in the vicinity. And that seems to be a widespread issue, that the plan of care indicates hospice aid services were needed or oxygen was needed, but there's no indication from the assessment and elsewhere in the notation, or excuse me, visit notes, that would prompt that oxygen or those change in aid visits. So what we seem to be doing, according to the surveyors, when they're looking at the documentation, they're saying, well, their process is probably just the same for everybody. I do the same documentation regardless of what I'm seeing with the patient. And we know that's not true, but that's what our documentation is leading others to believe. Sorry about that. I'm not sure what's going on with sound here. So let's, oops. I wanted to make sure I didn't miss a slide, so I apologize for that. Okay, detailed scope and frequency. This in and of itself is one of the survey deficiencies. At L547, we are required to have a detailed statement of the scope and frequency of services that are necessary to meet the specific patient and family needs, and we need to talk about those frequencies. They must be individualized, which means that they are based upon the patient's unique needs. So for instance, when the surveyor pulls out plans of care and sees frequencies of 2 times a week for the RN for almost all patients, yet she's seeing that the patients are different, that is an indicator that there's a problem and we're not really individualizing our frequencies, we're just writing routine orders. And the surveyor should see that the frequencies change as the individual's condition changes. Also, PRN usage. We'll see RN 2 times a week and PRN for on-call needs. Well, when you are using a lot of your PRN visits, you need to maybe change how many times that the RN is routinely going out and get an order for a frequency change. The surveyors aren't always seeing that happen. Those frequencies have to be for volunteers as well as other members of the team. And it's not really acceptable to have volunteers PRN. There should be an indication of why the volunteers need to be there PRN. We need to talk about 5 times a week versus 7 times a week. There are many, many instances in our documentation where the aide is going out and doing visits 5 days a week, yet the patient needs personal care 7 days a week. And the question is, why would the aide go only Monday through Friday? Because that's typically what 5 times a week means. Maybe it's that a family member is not working during the week and is going to provide personal care on the weekend. That's perfectly fine, but that needs to be indicated in the assessment, and that way the surveyor can see that you really aren't just writing standard orders that are for the benefit of the hospice scheduling and hospice staff, but really truly are based on the individual's needs and that family's circumstances. think we've talked about making sure that the goals and their interventions are based on problems identified in your assessment and your updates to the comprehensive assessment. Your number 2 top 10 deficiency is L545, and it must, in this particular interpretive guideline, it says that we must include all services necessary for the palliation and management of the terminal illness and related conditions, and then it goes on to talk about what those include, and I think this is pretty straightforward, but again, we don't seem to be doing this on a regular basis in our documentation. Again, the medications are an issue, and I just have this slide here for your reference. I want to actually show you what some of the problem is and talk about actual survey examples. So on our assessment, what we often see on the physical component of that assessment is that, again, the oxygen issue, there's no complaints of shortness of breath, there's nothing observed by the clinician to show that the patient has shortness of breath, yet we're putting 2 liters of oxygen PRN in every single home. Now, if the patient is one that has a diagnosis where you would anticipate the need for oxygen, but the patient doesn't need it right now, you need to ask, do I go ahead and put it in anyway and have it sitting there so that when they need it, they have it? Or do I continue to assess, maybe I make an extra visit during the week, but I continue to assess the patient's shortness of breath, and when that changes, we put the oxygen in. I mean, there's a lot of different considerations and factors that would go into making that decision, including financial as well as patient care. The point is that that assessment isn't always driving that plan of care, and that's what needs to happen. On the psychosocial side, there's an assessment that we would see conducted by the social worker, and maybe sometimes we don't even see an assessment, psychosocial assessment, but other times we're seeing that there are no needs identified from that psychosocial assessment by Susie's social worker, yet Susie is going out and she is seeing the patient every single month, and that's a pretty common frequency where we'll say social worker 1 time a month. Well, what is she seeing the patient for? What skills of a social worker are needed for this particular patient and their family? Again, everything has to be driven from that assessment and the problems that you've identified. And these frequencies need to change, what you're doing, all of your interventions need to change as a patient's condition changes. On the spiritual side, we might see a note that says the patient has not been to church in several years. They were involved in the parish until the patient's wife and pastor had a falling out. And then we see on the plan of care 1 time a month for ministry of presence. What does that mean? What does ministry of presence really mean? And based on the patient's condition, is 1 time a month enough? Maybe you need to go 2 times a week for the first week, and then 1 time a week, and then maybe adjust your frequencies after that. Those are some of the issues that the surveyors are seeing. And again, for bereavement, you want to see that there is some sort of bereavement assessment on that comprehensive, and that plays into the plan of care. So if the initial bereavement risk assessment was completed and it indicates normal bereavement risk, maybe there is no intervention, and that's perfectly fine. Maybe your intervention is that you continue to monitor. Obviously, you're going to monitor for bereavement needs on each and every visit, especially the social worker and the chaplain, but the nurse does that too. All of those things have to be reflected on the plan of care. What you should do in order to avoid survey deficiencies and to help improve patient outcomes is to do an audit crosswalk between your assessment and your plans of care. When your clinicians are focusing on those problems identified in the assessment and they have that plan of care in front of them, it forces them then to focus on the patient outcomes. And those outcomes sometimes get lost in the busyness of our day. I'm sorry that keeps popping up. I'm not sure why. That usually doesn't do that. Seems to do it only when I'm doing webinars, but do that audit crosswalk and see if all the problems on the assessment do carry over to the plan of care, and have somebody other than the nurse who wrote that plan of care or the team who completed the assessments actually do the audit. Look at whether or not all your problems identified are really problems, or if you can monitor those. Perfect example is a dementia patient. And some of your EMRs will even have a little indicator of most disturbing symptoms or even immediate needs. That helps you to helps the RN to complete the initial assessment. It carries over usually to the comprehensive assessment, but on those dementia patients, it might identify in that section of the assessment that one of the most stressing or disturbing symptoms for the patient is short-term memory loss. And I'm thinking if it's a dementia patient who's in hospice, that's probably not one of their most distressing symptoms, probably not a problem that you're going to identify an intervention and a goal for. It's those types of documentation that are causing problems on the plan of care. And it also means that your clinicians aren't really looking at what they've identified as the problem, because if they were really taking a step back after they completed their assessment and identifying the problems and saying, okay, what am I going to be working on next, it wouldn't be short-term memory loss, and they would pick up that that was documented in the incorrect box on the plan of care document, or that it shouldn't be identified as a problem. Is the plan of care being updated with new or resolved problems from the updated assessment? What the surveyors have told us they've seen is that there will be a description of the patient's problems at the very beginning of care, but that never seems to change. We don't seem to be resolving the problems yet. If we go to the IDG meeting and listen to the clinicians talk, they've resolved many problems, but they're not documenting those. I am very sorry. Try to get that to stop popping up. For the clinicians, they should be looking at that plan of care before their visit, as well as the previous visit note and the updated assessment to guide their visit. They should be making an actual, very targeted plan before they walk into that patient's home. They should be able to identify what problems they're working on or the previous clinician was working on, what the patient's response to the interventions has been, and what needs to be done in order to get the patient to their goal. What are you going to work on this particular visit? That happens all the time. That's typical nursing practice. Social workers should be doing that. Chaplains should be doing that on each of their visits. Sometimes the previous visit note isn't even in the chart, so it's hard to identify what's happened, especially if you're not the clinician who's been seeing the patient. On the other hand, if you are the clinician who has been seeing the patient and you say, oh, I know this patient, I don't need to look at that, that's the problem. It becomes habit. It's just like when your best friend or your husband or spouse is on a diet and they've lost lots of weight. You don't see it as much because you're seeing them all the time. When you have a situation where your documentation is driving your compliance with your requirements, your conditions of participation, and it's driving your payment, your conditions for payment, you've got to make sure that you identify those small changes and you keep on track with what you're working on in terms of outcomes for this particular patient. So you've got to actually make a very targeted, deliberate identification of those problems and what you're going to be doing on that visit to address those. Audit for consistency between your disciplines and between your visits of the same discipline. So for instance, the social worker and the chaplain are both seeing a particular patient, and one of the issues that was identified, if we go back to our example, was the spouse that had a falling out with the pastor at the church, and that affected her social circle. You will see maybe in the notes that the social worker has indicated that this is no longer an issue, that there's been some resolution to this, yet you'll see in your chaplain visits that this is still a major issue for the spouse. So which is it? And give us some examples, give us some detail about what leads you as the documentarian to the conclusion that there's no change or that something has been resolved. And again, the obvious one of auditing for compliance with frequencies and ensuring that all of your services, including your volunteers, do have a scope as well as a frequency listed. And let's talk for just a minute about the aides. One of the questions that I do sometimes get is, when the nurse is scheduling the aide and she puts them down for 2 visits and PRN, can the aide go out and decide on her own, that this patient needs an extra visit? And the answer to that is no. Just like a volunteer should not be deciding that the patient gets an extra visit. This is an IDG decision. The nurse, the social worker, the chaplain, all those necessary disciplines should be communicating about the scope and the frequency of the visit. Doesn't necessarily mean that everybody has to have a come-together meeting before the frequency is changed, but all of the individuals, including that attending physician, should be involved in those decisions and aware of what is happening with the patient. It should not just be nurse-driven. And then once we get that plan of care developed exactly the way that it should be, and our nurses and our social workers and our chaplains are using that plan of care as well as the updated assessment to drive their visit, meaning that they know what problems were identified, which ones we're working on, which ones have been resolved, what the interventions are, what the patient's progress towards goal has been. Once all that comes together, then we're not going to have a problem with our coordination of care deficiencies. Most of these coordination of care deficiencies, according to the surveyors, are related to frequencies, but it's also that we are not working together as a team, or at least our documentation doesn't show that. It shows very fragmented system. Number 6 on the top 10 deficiencies is nursing services. And this one is a little disturbing to me when I hear some of the examples. But the nursing care and services must be under the supervision of a registered nurse. In the example I gave just a slide or 2 ago about the aide being 2 times a week in PRN, the aide doesn't decide. The patient doesn't decide. The nurse, in the case of the aide, would be supervising that aide and changing that aide's frequency based on feedback that she's getting from the aide or a request from the patient or family. We have to ensure that the nursing needs of the patient are met as identified in the patient's initial assessment. Again, if we're going to write a problem down on the assessment, whether that be short-term memory loss or shortness of breath, we have to make sure that we address that. Everything identified in the comprehensive assessment, and then of course our updated assessment. Examples of the reasons that we have deficiencies in nursing services on surveys include on-call issues or issues where we're identifying a wound on assessment but there is no follow-through with reassessment. In one particular case, the patient caregiver had contacted the agency and told them that the nurse was needed. The nurse did not go out to that patient's home. 2 hours had passed, and the documentation showed that the first documented RN visit after that request was 2 days later. 2 days after that request was made. The patient was found when that visit was conducted, and it was actually another request by the patient or patient's family in order to get even that visit 2 days later conducted. It was another on-call request, but the patient definitely had some symptoms. They had fever, tachycardia, abdominal pain, and they were sent to the hospital and admitted. The caregiver called at midnight concerned that the patient was having difficulty breathing. Caregiver was instructed to administer morphine and Ativan. Caregiver called again 40 minutes later, was told that the nurse was coming, and was instructed to give more medication. The nurse called, instead of going, called at 1:25 a.m. and told the caregiver to give more medications, that she was on her way. She called again at 1:30 to report again that she was on the way and had spoken to the doctor. And the caregiver reported to the nurse that the patient had stopped breathing. Now those calls all occurred around 1, and the last one again at 1:35. The nurse did not arrive at the patient's home until 2:15 a.m. after that nurse was told that the patient had stopped breathing. Those are the types of reasons that CMS has concerns in these areas. Again, if we use those guiding documents, our assessments, our plan of care, our previous visit notes, or even a conversation with the individual who saw the patient prior to us seeing the patient, that will help to minimize some of these issues. Now, maybe not the on-call issue that was identified, but it would certainly help identify wound assessments that aren't having follow-through done, no reassessments are done on those, or other problems that are identified maybe in a visit note but never make it to the updated comprehensive assessment. Again, another set of eyes is so helpful because our clinicians really are trying to do the right thing. They're trying to document the right thing. They're often delivering the right type of care. It's not documented, but it's because we are in the forest and we can't see the forest through the trees sometimes. So we need another peer or a supervisor to review nursing notes. And in the on-call situation, because that does seem to be a very common thread in this particular deficiency, there should be a peer nurse or a supervisor on call for emergency backup, and also then to do an audit of the calls and responses on a regular basis so that we can provide education and make sure our clinicians know that, hey, we got 2 or 3 calls from this family and we didn't see them for 2 hours, what's going on? And then, of course, our favorite, supervision of hospice aides. Another top 10 deficiency. It's been there forever. I don't know why we can't get this right, but we can't. Our registered nurses are not doing their supervisory visits every 14 days, and I think every organization deals with that. You know what you need to do to put in place to stop that from happening. The aide does not have to be present during the visit. I've had some hospices say, well, it's so hard to get out there when the aide is there, and that makes it more difficult, and that's actually why they're missing visits. You don't have to have the aide present during each and every visit. But when you do an assessment, or excuse me, a supervisory visit, you are to assess the quality of care and services being provided by the aide and ensure that those services that are ordered by the IDG meet the patient's needs. So instead of just having a checkbox that says supervisory visit, there should be documentation that the RN has actually assessed these things and ensured these things, whether that be a form that you use that has this identified on it, or you actually have your clinicians write it in their documentation. Either one is fine, but part of the problem with the supervision is that we aren't supervising the right things. And audit for frequency. Again, I can't say enough about those frequencies. That gets us into a lot of trouble. Coordination of services. We have to develop and maintain a system of communication and integration per CMS to ensure 3 things. One, that the IDG maintains responsibility for directing, coordinating, and supervising care. ensure that the plan of care, those frequencies and the interventions are actually delivered to the patient. And again, if we were using our plan of care as our roadmap and we pulled that up in our IDG meeting and we looked at it before each and every visit, it would force us to focus more on the outcomes and to focus on ensuring that we are providing care in accordance with what it says that we're supposed to do. Okay, L671, this is related to clinical records. This is pretty straightforward. Sometimes the clinical record doesn't contain everything that it's supposed to, and that's pretty common. Not so common, but it does happen, is that the clinical record cannot be found. I would hope that that would be more uncommon than what some of the surveyors have told us they're finding. Sometimes surveyors think that a record can't be found because the hospice doesn't want them to look at it. Let's not have that happen. Make sure you don't lose any of your records, and that should be easier now that we have, in many cases, EMR. But also, in addition to not being able to find the record, and this is more common, there's not a signature on those components of the record that require a signature. There's not volunteer notes. This is very common, where the volunteers, instead of being a documentarian in your EMR system, they're documenting manually. That's very common, understandable, but often those volunteers keep that documentation, don't turn it in timely, and then when your surveyor arrives, the volunteer might be out of town, so the agency can't get the records. That is going to be cited under clinical records. You don't have a complete record. And more importantly, you don't have information that that volunteer might have seen that is going to drive what you're doing in your plan of care. You might not have information that shows that you are effective with your interventions because that volunteer doesn't have their documentation there. Do not let the volunteers keep their documentation at home. You've got to set some sort of parameters with them so that they turn those in on a regular basis and that they are complete. And likewise for your nurses and your chaplains and your social workers, their documentation should not be occurring in the home on a regular basis. And I don't want to get into that conversation about the personnel issues associated with that, but strictly from the standpoint of having information that your staff needs in order to follow that plan of care and to see if you're really being effective in your interventions. All of the documentation is important, especially when it's the visit prior to the visit that you're making today. So you've got to have some enforcement of the parameters around the timeliness of that documentation and where it's kept. And the more staff you have doing their documentation at home without enforcement of parameters means that you're missing very important communication to other clinicians, also missing important documentation that will help you get paid and help show that you are actually achieving the outcomes that you set out to achieve for these particular patients. An audit for signatures and dates. It's so easy to put a signed piece of paper in the chart and it doesn't have a date on it or it doesn't have a signature on it. Make sure that the person who is doing the filing is really looking at that before they put them into the chart. And then, of course, to audit for a visit note corresponding with each visit to make sure that you have those coming in. I'm sure that if your clinicians were using the prior visit note in preparation for their visit, they would know that that prior visit note was missing. So that's an extra set of eyes to help you on that side. Okay, this slide is the references that they were towards the beginning of our presentation as well. I've stated them here again to make sure that you have all of these and you can find the guidance that the surveyors are using and the guidance that all of the MACs are using in determining whether or not a plan of care is present. Sometimes on the condition of payment, when they're denying payment based on a plan of care, they're seeing that the plan of care was not fully developed. It just simply doesn't exist. All the components to that plan of care don't exist. So make sure that those are clearly identified in any of the documentation that you would send in for a medical review. Make sure that those components that need to be signed are actually signed. Sometimes the signatures show that the attending physician was involved. Make sure that that is present.